Devangi from Clinic Spots. Today we have Dr. Pramod Bhor with us. He is a leading orthopedic surgeon in Mumbai. So there are many queries which we have about knee replacement. So the doctor himself is going to answer all the queries related to knee replacement. So first of all, what is knee replacement?
Knee replacement is basically a surgery for knee pain. I would say all knee pains don't require knee replacement. Whenever there is osteoarthritis, means there is damage to the cartilage to the joint, then the knee replacement is done. What we do in a knee replacement is we shave away whatever remaining debrided bad cartilage is there, and we resurface the joint with a new metal. So this is how a normal knee looks like, which has got a good cartilage. This white thing is what you see is the cartilage. In an arthritic knee, the cartilage is completely worn off. What we do in a knee replacement is we just shave off this cartilage, shave off this part, we make it in such a phase that will fit onto the replay to the metal. There is a metal implant that is fitting on the femur, on the top bone, a metal implant that fits down below, and a plastic implant that stays in between to give smooth movement. So basically, an idea being to do a knee replacement is to give a painless mobile knee. A patient has to be able to walk pain-free. He has to be walking straight, and he has to be able to do all his regular activities. So that is the basic idea behind doing a knee replacement.
Okay, and what are the signs which indicate that a person needs knee replacement?
Signs means ideally speaking, a replacement is a surgery for always pain. So if the patient is having a pain which is persistent for a very long time, not getting treated with medicines, even with all kinds of painkillers, as well as with exercises, with hot fermentation, with all conservative physiotherapy, the pain is not managed, the pain is persistent, and definitely the patient requires surgery. All the other means of treatment, as in which are conservative, have to be done before doing a knee replacement. So I normally make it a point that the patient undergoes any other kind of treatment which is non-surgical before ideally doing a knee replacement. The common sign or symptom is pain, inability to walk, so much so to that the patient is not able to do his daily routine activities. So a patient whose activities are restricted, he is not able to do his daily work, should undergo a replacement. That is the basic sign for a replacement.
And are these knee replacement surgeries permanent?
Yes, they are permanent, because once a knee is replaced, you cannot unreplace it. Whatever we are doing, we are removing the cartilage which is damaged. We are removing the meniscus which are supposed to give a cushioning in the joint, which is already damaged. So we are removing the damaged cartilage and the cartilage and the menisci, and replacing with the prosthesis, which is metal and polyethylene. So definitely they are permanent. Once it is done, it is done. That is why we take utmost care to do it. It's once in a lifetime surgery. Once it is done, a replaced knee is a replaced knee.
Okay. And which are the best knee replacement implants?
There are quite a few to say. See, if we have to classify a knee replacement implant, frankly speaking, we can classify them upon the material. Number one, we can classify them upon how they work, and basically how much mobility they give. So if we classify them upon material, either a cobalt chrome metal or a titanium metal is used. Nowadays we have got gold knee implants as well, or oxynium. Oxynium is basically used for patients who have metal allergy. So in those cases we are using oxynium implants. Along with that, there is always a spacer which is polyethylene. The polyethylene spacer normally we nowadays use a highly polyvalent vitamin E poly, which is highly cross-linked vitamin E poly, which is stays on for a longer time. So nowadays with newer implants coming in, which have a better poly, the implant stays on for a longer time. So that is depending upon the material that is used. Depending upon the function, there is a normal joint this thing, and there is a high flex joint. High flex joint normally gives around 30 degree of more flexion in the knee movements. So, but there is some more amount of bone loss that is there when we are doing the replacement while using a high flexion joint. So normal flexion knee and a high flexion joint. These are the two kinds of implants that are there.
And what is the success rate of knee replacement?
Success rate, ideally speaking, if you are asking me about the success rate is around 99 to 100%, I would say. There are definitely some complications, but the complications have to be kept to the minimum. The complications are ideally infection, loosening. Loosening is not a not an immediate complication. Infection is the only immediate complication that we foresee. Secondly, other complications caused by the comorbidities, because these replacements are majorly done at an older age group. So whenever we are doing these replacements at an older age group, we have to always take care that the comorbidities are taken care of. So we make it a point that all the other diseases are treated prior to the replacement. The infection rate is low, should be low. For the infection rate to be low, we normally have to take care about the OT. We have to take care about the personnel handling the implants, personnel handling this thing, and the expertise of the surgeon. So that is one thing which I make it a point. My team is up to the mark. I do not let them miss a single step. That is the main thing about a replacement, because it's a permanent surgery. So we have to make it a point that you don't miss a single step.
How safe is knee replacement?
It is very safe. It is really very safe. Once it is done, the patient walks the second day. He is sitting by the bedside by the end of the day. Even if I am replacing both the knees on the same day, I make it a point that the patient is standing the second day. When the patient is standing the second day, he is walking. Third day or the fourth day, there is step climbing, and by the end of the week, he is back at home with the walker or without the walker, depending upon patient to patient. Maximum amount of time the patient requires to use a walker is maybe around 3 weeks. Patient goes back to his normal day-to-day activities which was there prior to his pain, maybe in around 1.5 to 2 months, depending upon how nicely they do the exercises and how they follow my advice regarding this. So overall, knee replacement is quite a successful surgery as compared to any other trauma surgery, and it is the recovery rate is also earlier, faster, because you are walking the second day of surgery.
Also, how a person can prevent knee replacement?
Now that is a very big point and very important point. Majorly 80 to 90% of the 80% of the population can prevent. 80% of the patients undergoing a knee replacement can prevent it at an earlier stage if they detect it. What happens? People tend to ignore the pain. They don't tend to treat it when the pain starts. Okay, it's the attitude of a person. Okay, it's my age, my knee is going to pain. So that is how they try to neglect it. If any pain treated at an earlier age group, whenever it starts at an early stage rather, will help to reduce the incidence of knee replacement. Secondly, taking care of your weight. After the pain subsides, regular exercises, regular diet is important, because any knee replacement is for osteoarthritis. The knee undergoes osteoarthritis whenever there is deficiency. So either deficiency of the ligaments or the deficiency of the bone calcium or the cartilage can cause osteoarthritis. So to reduce the deficiency, we have to strengthen the muscles. The muscles and the ligaments are only strengthened by exercises. The bones are strengthened by calcium and vitamin D supplements. So we have to take care of our bones and muscles. The skeletal balance must be maintained. If that is maintained, then definitely the incidence of replacement can be reduced. Secondly, any previous small injuries or any other conditions like rheumatoid arthritis and everything should be treated. We should not neglect our smaller injuries, any knee sprains, any ligament injuries, meniscal injuries, which happen during our playing age group, or I would say younger age group. So those injuries have to be treated. We cannot neglect them. If we are neglecting them, then there is more chance that we have to undergo a replacement at an earlier age group, or the joint becomes arthritic at a later age group. We have to take care that the sports injuries also are to be treated, and they can be treated at a very in a very minimally invasive way by doing an arthroscopy, which we do at a regular interval, basically.
And what if a person doesn't want to go under knee replacement? Is there any other treatment?
See, again, as I said, there are treatments. Any patient coming to me with knee pain, I do not advise the patient knee replacement on day one. The patient is earlier treated with painkillers, physiotherapy, hot bags, exercises. Then there are walking aids, as in belts, braces, knee braces. Knee braces are also of many types, basically normal kneecap, hinge kneecaps. There are OA knee braces where there is offloading braces where your weight gets transferred to the brace completely. Then we can give them intra-articular injections. Intra-articular injections again range from simple steroid injections to nowadays we are giving them hyaluronidase injections. Hyaluronidase injections basically normally they replace the joint fluid and causes decrease in the friction in the joint surface. So that is how they reduce the pain. So intra-articular injections can be given. There is one more way, that is arthroscopy. So arthroscopy normally gives wash in the joint. It debrides all the dirty tissue. We normally take care that the joint which is causing huge amount of friction, the joint is again smooth. So that is how we reduce the friction in the joint by doing an arthroscopy. There is one more surgery that can be done, is the partial knee replacement. Even partial knee replacement, instead of a total knee replacement, we can do a partial knee replacement also, where which is done at an earlier age group. So whenever there is a starting of a replacement, only a single compartment, only this compartment is involved, we can do a partial knee replacement. But if this compartment also starts getting involved, we will not be able to do a partial knee replacement. So whenever there is a single compartment involved, we do a partial knee replacement. So that is how the incidence of a total knee replacement reduces.
And if a person has undergone the hip replacement surgery, can the person again go can he do knee replacement surgery also?
Definitely. A person who has got a hip replacement can do a knee replacement, or a person having a knee replacement can also do a hip replacement. That is not a problem at all. So a person with a hip replacement can do because ideally speaking, it will reduce the strain that is coming on a replaced hip. If the person has a bad knee, there will be more strain on the replaced hip. So we have to take care that strain also reduces. That is how that hip also will stay better if we replace the knee. There is no problem in replacing the knee. Even a person for whom we do a partial knee replacement can undergo a total knee replacement later, because that is easy to convert. But doing a partial knee replacement will normally decreases the incidence, or even causes the knee replacement to go at a later age group. Instead of doing it at an earlier age group at 55, 60, the patients undergo total knee replacement around 70, 75. So that is how we normally want to delay the replacement.
And what are the myths about knee replacement?
The common myth in our country or anywhere is that I will not be able to walk after doing a replacement. I will not be able to jog. I will not be able to move around. That is a total listing. I will have to be in bed for 2 to 3 months. That is a very common thing. So that is not the case. The patient walks the second day, maybe with the help of a walker. It's not that he is walking the second day without any walking aids. He is walking with the walker. The walker normally, as I told earlier also, the walker normally is there for around 2 to 3 weeks. depending upon patient to patient. If the patient wants, if they are confident enough, they can leave it on their first week itself before going out of the hospital. So normally the patient is there in the hospital for a week. Before that also some patients leave a walker. Some patients require it. Maximum I have seen them using it for 3 weeks. After that I have not seen any single patient using a walker in my case. Secondly, not able to walk, not able to run. That is totally not at all true. Whatever activity your muscles or your age allows you to do, you will be able to do. And that is not at all the case. The thing is, only thing that normally we ask patients to avoid is to squat, not to squat and not to sit cross-legged. That two things should be avoided. That is not because they cannot do it. It's basically because for the longevity of the joint. If you are not doing that, the joint stays better and it stays more healthy for a longer period of time. So if you want to have a successful knee replacement, regularly exercise, regularly move around, do not squat, do not sit cross-legged. That is the only thing that we tell the patient.
When do you do a partial knee replacement?
Partial knee replacement means we are just replacing the part of the knee. We are not replacing the complete knee. As we can see here, this is the whole knee. There are 3 compartments, 1, 2, and the third compartment is in the front, if you see here on this side. So whenever only a single compartment on the medial side or the lateral side is involved and we replacement only that part, then it is called as a partial knee replacement. So it is done in early osteoarthritis. This normally helps in reducing the progress, or it helps in stopping the progress of the disease. So whenever a patient we see at the age of around 40-45 who has knee pain, regular knee pain, only on the single side, if we do an X-ray and there is a decrease in the space on the joint on one single compartment, that time we do a partial knee replacement. It is becoming very common nowadays, with all people doing regularly regular marathons, regular jogging, regular running, and doing all sorts of activities specifically which go unscrutinized, or even without proper training, the people are going on for all these activities. So that is why it is becoming very common. So whenever there is a single compartment involved, that time we do a partial knee replacement, so that the progress of the disease is late. Normally if you would have left it that way, then say around 40 years of age the patient has a involvement of a single compartment. By 45 we are going to require a total knee replacement. By doing a partial knee at the age of 40 or 41, what we do is we prevent the progress, and so the patient goes without a total knee replacement up to the age of 45 maybe, sorry 55. So we just make it a point to take away 10 years of the replacement without doing a major complete total knee replacement. And the advantage of a partial knee is the patient is able to do each and everything on day 2. He is even able to squat, even able to sit cross-legged after doing a partial knee replacement. There is no restriction at all. So that is an added advantage of a partial knee replacement.
And what are the post-surgery measures which a person should take?
Post-surgery, now see, again going back to how I normally ask a patient to mobilize. Surgery, if the surgery is done on day 0, day 1 I ask the patient to sit with the legs hanging down, start with knee flexion and extension exercises. Secondly, I ask the patient to stand and start walking. So day 1 the patient is walking, day 2, day 3 the patient exercises further. On the 3rd day the patient is asked to do step climbing. Maximum by the 4th day the patient is step climbing, and the 5th day the patient is discharged from the hospital. After the hospitalization, the suture removal is by the day by 12th or the 14th day, by 2 weeks, and after that the patient has to regularly exercise. The most important thing after in post-operative care is regular exercise. The patient uses a walker to walk maybe for a few days, as I said earlier also, maybe for a week, maybe for 3 weeks, but the exercises is a mainstay of treatment. Secondly, he has to take care not to squat, not to sit cross-legged. These are the only restrictions that will be there with the patient. Patient has a complete range of movement from 0 to 130 But squatting and sitting cross-legged is the only restriction that I normally advise a patient. Most important thing is to exercise. If the patient regularly exercises, and these are simplest exercises, you don't require, the patient doesn't require any special physiotherapy or long-term hospitalization to continue with these exercises. Patient can learn the physiotherapy when he is there in 5 days in hospital and continue them at home. It is that simple.
Thank you, doctor, for all your precious time and your knowledge.